Thank you very much, Ulrike, and thanks to GS1 for this phenomenal opportunity to share with all of you the work we have done in Nicaragua. I just hope that my presentation today really is a catalyst for change, specifically in the developing world, where I am exposed to all the challenges that are there, and that it really brings partners together. The developing country is not one of the easiest territories to work in. It's where the greatest needs are, just from medical and just from infrastructural standpoint. And so for me and my colleague Ray Lazardi, who's here with me today, he has been very instrumental beside me to make this project that we did in Nicaragua a reality. And I am really excited to share it with you. And I think what we discovered here is phenomenal. And so without further ado, let me just get into the agenda because I know we're sort of going against time and we're on the final countdown. So over the next 20 minutes or so, what I will do is share with you a very brief background on vaccinations in low-income countries, some of the challenges to improve child health, and how the introduction of barcodes can ultimately help vaccines reach children safer, quicker, and on time, and ultimately help to save the lives of millions of children. Oops. We have advanced tremendously technologically, but yet still today we are struggling to protect many of the children in low-income countries. I'm sure that many of you may or may not know that children in the developing world are 10 times more likely to die than children in the developed world. And while substantial efforts have been made to improve child survival, unfortunately, a lot of progress is still lacking. It is unacceptable, and I'm sure that all of you will agree with me, that today, in 2017, still, approximately 16,000 children die every single day, and that equates to 11 deaths occurring every minute. So in the 20 minutes that I will spend presenting to you, about 220 kids will potentially lose their lives. More than half of childhood deaths are under the age of 5, and these are due to diseases that are preventable and treatable through very simple interventions. Interventions such as clean water, access to vaccination, and proper nutrition. Immunizations in particular, data will show, have averted an estimated 2 to 3 million deaths every year from diphtheria, pertussis, and tetanus. And we have the opportunity, if we all work together, to avert an additional 1.5 million children if global vaccination coverage can be increased and improved. The 2016 World Health Organization global vaccine coverage stands at a very low 40%, which means the vaccines are not getting to all the kids at the time that they need it. So we have got a great deal of work to do, and it will take strong partnerships to do this, governments, industry, and non-for-profit organizations. It's a huge undertaking, but I am optimistic that we can actually make such a vision a reality. Today, in the developing world, there are about 6 to 8 vaccines in the national immunization programs of these countries. But how do we know that these vaccines are getting to the children who need them and getting to them on time and in a safe manner? The supply chain from manufacturer to a child is often long, very fragmented, and especially so in the low-income countries. Obviously, product diversion is another concern we think of every day. So what can we do to address these challenges? How can we implement a system to better manage the vaccine supply? Certainly, advanced technology has a solution. In the year 2000, with the formation of the Gavi Alliance, an increased number of vaccines began entering the low-income countries. And by 2010, newer vaccines that address pneumococcal disease and diarrhea and the HPV vaccine also began entering the developing countries. This became a concern to the World Health Organization and the Gavi Alliance, as well as UNICEF. And therein became the thought, how can we track these vaccines and also trace them in the event of a need to trace them? So in 2014, based on the work of the subgroup of the Vaccine Packaging and Presentation Advisory Group, the World Health Organization adopted their recommendation for manufacturers to place the 2D barcode on all vaccine packaging and that the barcode should conform with GS1 standard and associated specifications. Following that WHO recommendation, Pfizer became the second pharmaceutical company to add the barcode to its pneumococcal vaccine packaging. Having done that, and where I sit in the company, I do work with our manufacturing colleagues, I do work with UNICEF, and I do go down into countries to actually see points of vaccination and to work with ministries of health. So because of where I sit, knowing all of the challenges we have in the developing world, and now having the barcode on our packaging, my curiosity was, well, I want to see the 2D barcode in action, because one of the things we've always said to ourselves, what is the value of a vial of vaccine if it's sitting on a shelf? And so my question was, what is the value of that barcode if it's just sitting on the packaging and we have not operationalized it, and we cannot talk about how it works, and we cannot talk about its benefit, and very precisely so in the field of immunization and in these resource-constrained countries. So we developed a pilot with the following hypotheses. Accuracy. Can barcodes eliminate human errors? Efficiency. Will it allow for faster processing? Visibility. Will we have an opportunity for real-time data? And data security. Can we have one central server instead of various copies at different stations? That was our hypothesis. But as you've all heard from the different cases, it is always good to do your homework and gather as much facts and data as possible to put your strategy and your project forward. So having our hypotheses, we also decided to look at what else was going on around the developing world that we could potentially learn from. So when we embark on our project, we would have been taking on as much of the challenges and overcoming those as we go. So we looked at pilots that were in Ethiopia, in Tanzania, and in Pakistan. And what we found were some interesting challenges from these three projects that were going on. And a couple of the challenges that I will highlight that we found are that capturing barcode on mobile smartphones can sometimes prove more challenging than actually using the hardware scanners. Also, a project of automating inventory management will become very limited if the barcode is not on all the packaging. And lastly, scanning can become very difficult in low lighting conditions, and obviously the size of that barcode also can make it a little difficult. So knowing all of this, we sat down and thought about it, and we thought, heck, there's a lot of work that needs to be done if we're going to create an automated inventory management. So based on these findings and our proposed hypotheses, we decided to work with PATH, Accenture Development Partnerships, and the government of Nicaragua, who graciously gave us permission to conduct this pilot in her country, to further advance the proof of principle software, which was a very simple technology that Tanzania was testing for our project. And what evolved for us was a tool that the local team in Nicaragua named the Vaccine Visibility System, or VVS. It integrated the GS1 barcode scanning with the country's operational processes and reporting requirements. The VVS software was tested in 7 sites in Nicaragua, from the central to 3 districts and to 3 municipalities. We did not include the health centers or the point of vaccination in this pilot. Reason being, the point of vaccinations in Gavi-eligible or low-income countries it's oftentimes a very small room with very little space for a computer and scanner. Sometimes it's just a little desk crowded with moms and babies. Sometimes it's outside the clinic in the big open yard space. So for those reasons, we did not include it in this pilot. It would not have helped us to do anything efficient or valuable there. So what happened in this pilot is the last dispatch in the system was from the municipality to the health center. And one of the things that we quickly learned as we observed the pilot was our system was not closed loop. And so when that last item went from the municipality to the clinic, it was always in the system as in transit. Unfortunately, because of the time of my presentation, I will not be able to elaborate a little bit more on all the learnings we've had, but obviously at the end of the presentation, there's my contact information, and I'll be happy to share those with you. So how did we do this? What was our timeline and our implementation of this methodology? So I'll quickly walk you through those. So in July 2015, we did a very thorough study and documentation of the Ministry of Health processes, and we also did a gap assessment such that it would help us to further advance and develop what we were proposing to do. And in August, in August, a final technical design specification was shared with the path development team. In September, a complete system was developed and tested in accordance with our assessments and the Nicaragua distribution system needs. By October, we began rolling out the barcoding solution to the 7 sites and installing all hardware and software at each pilot. And because I was so passionate about this project, I also found a way of donating, along with Ray, who actually is in business technology in Pfizer, all the equipment that we used in this pilot. Once we had everything set up, we also created user manuals, and we conducted user training for all the field-based users. And so from December 2015 to April 2016, we monitored the system usage directly and continued to troubleshoot on all issues on an ongoing basis. The results that we found were phenomenal as we look at them from our hypotheses. What the pilot demonstrated was a 92% increase in the vaccine visibility system of collecting and reporting data. The accuracy was there. There was no doubt about it. The most significant advantage of the VVS system was its ability to accurately integrate data between the sites at the different levels, given this was a web-based tool. There was a 68% reduction in time per transaction, which means that when you were manually recording one transaction, it took 1 minute. Scanning that barcode took just 18 seconds. There was total visibility of data throughout the system, again, because it was integrated. And one of the things that our national immunization directors loved is that from their desk, they can actually see through their distribution chain how the stocks were moving from one place to the other, and so they can more easily control and make decisions and avoid stockouts, which is very prevalent in the developing world. There was absolute data security because there was one central server instead of local copies in local hard drives at different points. This system is now scalable for all of Nicaragua, and it's ready to accommodate every other medicinal product that may carry the GS1 barcode. It is also adaptable for other countries, and I'm very happy to say that right now we are embarking on trying to implement this in the Gambia. So exciting. I'm happy. I was curious to understand how the barcode worked, and I'm happy that we were able to actually carry out a pilot. So our task now is really to come together as partners and to continue to educate on the importance of barcodes and the significant benefits it certainly can yield. And I have got to say, because I have traveled so much around the world and I have seen all the challenges, I truly cannot emphasize how this is so beneficial and so important for the developing countries. They are really in bad need of this. And so it's also on us, the pharmaceutical industry, to ensure that we're prioritizing the inclusion of the barcodes in our vaccine packaging, because this can simply make a difference between the life and death of a child. Governments also need to prioritize the plan to get inventory management into their system. Obviously, it entails cost, it entails time, but if you make this, and if governments make this a priority, it can be done. It's a matter of really educating them on what the benefits are. And a few of my colleagues from before, I've heard it over and over, culture change is one of the big challenges. And I've got to say, throughout this project, we didn't find the culture change. It was embraced, it was wanted, because they saw what they were doing versus what they can do. And I think what's needed really is the education to immunization teams and governments in really explaining what can be done and what can be different. And this hasn't been moving. So with that, I am going to conclude my presentation in saying that, this conference was about one world, one standard, one vision, improving patient safety. And it is with that vision that we need to address the developing world challenges and help to support new technologies to the healthcare systems. And so I would like to urge us to consider that nothing gets done without partnerships. Partnerships are vital. Each one of us have our own area of expertise, and when we pool all of those together, only great things can happen. And I stand here for all the children in the developing world and for all of us, and hope that 220 kids did not die during this 20 minutes that I spent here talking to you, and that we certainly will find a solution to help vaccines get to children safely, on time, and every time. So with that, I thank you very much for spending the last 20 minutes with me. Thank you.